Great. All right. So, so the issue is you want to know when patients aren't doing well. And the other reason why it's important to use tools that help you to really have a measurement for behavioral health is that what gets measured gets treasured, and especially in this environment where there's a lot of pressure to show the value for care that's being provided, and quality measures are often the administrative leadership's way of deciding what we focus on. We don't want behavioral health to get left out because people think it's too complicated or there's no way of measuring how people are doing, when in fact that's not the case. And especially when you think about detection of mental health in primary care settings, if you rely completely on the patient to indicate that they're not feeling well, you're going to miss a lot of cases. So measurement-based care is the systematic administration of symptom rating scales and using those results to drive clinical decision-making at the level of the individual patient. And there's a citation at the bottom for a paper that describes this in greater detail than I have time to go through today. But basically, measurement-based care is designed to try to prevent unintentional inertia, which is a patient comes in, they're not responding to treatment, but the provider fails to detect that treatment non-response, and therefore they end up keeping the same plan despite the patient's lack of improvement or clinical worsening. And we developed an issue brief along with the Kennedy Forum, which you can download, that talks about specific measures that can be used for adults and children. They're not the only measures, but we don't want people to stop for lack of which measures should we use. So this supplement describes a list of measures that can be suitable for measurement-based care. We also have some instruction for payers to make sure that they're using measures. If they're going to try to encourage the use of measures, they need to be clinically useful, time efficient, and facilitate monitoring at an aggregate level. And we also don't want to penalize providers that are caring for a more complicated population, so you have to account for the case mix severity. So a very quick story. I came to Grady in 2011 as part of a clinical practice change effort resulting from a Department of Justice settlement agreement, which closed down the state hospital and invested in community resources. We had an initial effort in 2011 focusing on the emergency departments, but as a parallel effort, we were working in primary care. And this is a paper that we published from the pilot version of what I'm talking about today, which is a self-service kiosk that we developed to identify behavioral health needs in primary care. And this is a very underserved population. There were a lot of questions about whether or not we can do it, but we had a small $20,000 grant to develop the technology to have it be a standalone system that could print out the results for a primary care provider, and we provided training to the providers on how to use it, and it was what patients would engage before they would see their provider to try to address some of the time constraints. So the goal of this type of system is to improve the detection of significant symptoms, to also demystify the black box of mental health so that these are specific conditions that are identified and assessed for. And also, as I mentioned, there are significant time constraints in primary care and oftentimes difficulty engaging patients proactively in care. And these types of technologies can be used in the waiting room and can be used to help engage patients in care. So it's all about providing tools in the toolbox for providers and staff and patients to share information effectively. The biggest challenges that I had in this pilot project is the lack of knowledge on my part around intellectual property and technology transfer. I, in fact, knew nothing about intellectual property. I just was a clinician with the problem, figured out a way to solve it with a partner, and just went off to the races. I also wasn't very interested in business aspects of anything, and in fact I had kind of an aversion to early attempts to tell me that this is something that I should probably look at commercialization potential. That's probably because I'm a little bit risk averse in terms of my personality, And it was just a low priority. I had a lot of other commitments, and my providers at that clinic were happy, and so I was happy and, kind of not really looking forward. But I worked with Morehouse School of Medicine's Office of Technology Transfer, also got some mentorship from business leaders, other technology leaders that I happened to meet that helped walk me through the process of my options of establishing a company, of looking at the commercial potential of a technology. So I'm still kind of a learning work in progress. But we did get to the point of developing a patent application and a trademark application for what we're calling Psych Sit Rep, which is a software service solution that enables assessment of behavioral health decision support, which can be delivered on a kiosk, tablet, or similar device for behavioral health assessment. Again, we developed it initially in primary care. Now, for the purpose of this webinar, it does include measures that you probably recognize, the DAS-10 and the Audit-C for drug abuse and alcohol, but it also includes other validated measures because often these conditions are co-occurring. So using that algorithm, we were able to screen for all of these things in a 5-minute period of time that the patients do before they see the provider, and that's really the essence of what this technology is for. The point of this slide is really to point out that sometimes you have a goal that you're trying to get to, and there's these barriers that you face, and for me it was the whole technology part of it, and I've had to reach out for support to try to overcome my own limitations, but also some of the startup barriers, since there's certainly a demand when I talk to the market, so to speak. There's a big demand for solutions like this. And I will stop there. I think there are some questions that were given in advance that I'll take, and then happy to answer any of your questions at the end of the webinar.
Yes, we do have 2 questions for you, Dr. Wren. First question, how can clinicians and health professionals ensure that a mobile health intervention or an app is HIPAA compliant?
That's a really great question. It's usually the first question that practices will ask in terms of implementation. And usually in the description of the app, they will have specific language speaking to the HIPAA compliance aspects of it. In this case, our pilot effort did not collect identifiable information. So the pilot project, it didn't even connect to the internet because I needed to get the pilot data to see if it was feasible. So we only collected, we only analyzed de-identified information, and the actual data was hand-delivered from the patient to the provider and scanned into the medical record that way. Now, all you clinicians are probably recognizing that that's not very helpful if you want to look at change scores over time. You have to find some way to input the data into the electronic health record and integrate it that way, and that's where the issues around data protections and HIPAA compliance will come in. So in our current state, that's what we're doing when we're looking at integrated implementation, making sure that we address data protections using encryption so that protected information is not vulnerable.
Thank you. Our second question. As we know as health professionals, addiction oftentimes disproportionately impacts marginalized communities. Can you share any insight on strategies that poorly funded healthcare centers can use to ensure that they have access to these types of technologies, such as your kiosk or Mr. Procop's application on site?
So depending on the nature of your practice environment, you may have certain resources available to you. For example, if you're working at a federally qualified health center, there may be certain grant opportunities that are prioritized for that type of safety net clinic. And then you could also partner with a vendor or developer who's interested in addressing underserved populations. For example, all my pilot work was done at Grady, which is, underserved public hospital system. And that was also intentional, and we have a goal to try to make sure that our technology is widely accessible. But I would also say that you shouldn't underestimate the value of the knowledge that you have in engaging communities in dialogue around these issues. And I would highly encourage any provider to use their own self as a resource and getting outside of the clinic walls and engage in discourse with their communities about these issues, and also share the tools with community members. I've always felt that if the patients understood in advance that they can use these instruments themselves to identify, to kind of self-identify, that would also help a lot in case finding.
Phenomenal, thank you. And now we'll transition to Mr. Procop. So Mr. Procop, you may be muted. You want to ensure that you unmute yourself.
How's that? Can you hear me now?
Perfect, yes.
Okay, I'm the CEO and founder of True Medicines. And I worked at Microsoft for 16 years and worked on the Xbox Connect product, which is a computer citizen product. In 2013, I left Microsoft and started working on the tracking of pharmaceuticals. And the reason why I did that is people ask why do we need to track pills individually. One of the biggest reasons is that all types of pharmaceuticals have been counterfeited. And so the logos, the serial numbers, the barcodes, the looks of the pills have been counterfeited. And there's a wash of counterfeit pills around the world. And so there needs to be a method of identifying individual pills outside their packaging. Basically, when a pill has been removed from its packaging, there's really no way to identify that pill unless you're an expert, and even experts have trouble. Another salient feature for clinicians is that clinicians, according to the CFR, needs to have a diversion control plan that prevents drugs that are opioids to get out of the hands of the patient and into people that weren't prescribed. There was a 2013 HHS survey done that said 68% of all opioids were legally procured but were given by friends and family to opiate abusers. So that's a big problem that I think tracking individual drugs can help solve. Here's a slide that talks about the increasing numbers daily of overdoses with transitioning from opioids to heroin and then laced with fentanyl. And fentanyl is the big problem we're facing right now. What happened in 2013, the Congress passed the Drug Security Act that was a 10-year rollout of when drugs were going to be tracked using various methods along the supply chain. The first big step in that tracking process was going to happen in October of this year, and there was a survey done by all manufacturers, and they found out that 3/4 of the manufacturers were not ready to implement a serialization of their products. So it looks to be a big problem with the big pharma's having, and what True Medicines is trying to do is produce a turnkey solution for manufacturers that can track their drugs completely through the supply chain, from manufacturer through distribution center to the pharmacist. This slide shows the story about Walter White and his counterfeiting of drugs, and Walter White was actually replicated off a real guy named George Marquette, who was called the Wizard of Wichita. And George Marquette just got out of prison after 22 years. And George wasn't making meth in a lab, but he was actually making fentanyl. And so he just saw the light before everyone else. But fentanyl is a very difficult drug. George was able to manipulate the molecule so it looked like the drug he was making came from different laboratories. But actually George was supplying the whole country with fentanyl. Here's a picture of a sack of flour. And if you had a sack of flour full of fentanyl, you'd be able to produce over 1 million tablets. And you would get $45 million from selling those tablets. And then the next challenge coming up is carfentanil, which is 100 times more powerful than fentanyl. And of course, this becomes a real problem with smuggling of that drug into the United States because it's so small and so powerful that you could put 1 million pills in a salt shaker. So this is a problem that we're going to face for the foreseeable future with that. And here we have a demo of our application identifying a pill. I'm not sure if this is going to work. You should be able to hear the audio. I'm not sure how many people are seeing or hearing this. If you could text me, that would be great.
So currently the video is not playing. However, we will ensure that all persons who register have access to the video.
Yeah, it looks like the lag time for this video is not reaching this big audience. But we can provide a link to this video in the notes. An interesting thing about this drug that it's identifying, it was a drug made in the Kilimanjaro School of Pharmacy in Moshi, Tanzania, under the help of Dr. Joseph Fortunak from Howard University. And it's a coincidence that last webinar, Dr. Chapman was also from Howard University, showing his app for a spoke and hub application in the Washington, D.C. area. So they're doing a lot of good work in Howard University. This slide is an example of how fentanyl can look like an oxy pill and very difficult to identify. But using computer software and computer vision, we're able to take a close look at these medications and identify all the spots and speckles that are in Schedule II drugs, particularly. And you've all heard this story that snowflakes are unique to themselves and no snowflakes are the same. Well, this holds up true with spotted speckled pills. It's like having 100 snowflakes on the surface of a pill. And of course, human eyes can't really see that, but of course a computer and cell phone camera can see all those little speckles. And so this makes this pill extremely unique, and that all pills are actually pressed with a unique identifier of the granules that they have inside the pill. And they've been taking pictures of pills for 25 years. In the pharmaceutical manufacturing process all around the world, in factories and at packaging stations, packaging companies. And here's an example of a high-speed camera that takes 130,000 images of pills an hour. And they basically look for any cracks or misshapen pills during the manufacturing process. So what we're doing is leveraging that information, and we ask them to upload after a production run all the images they have of their pills up to our database, and so we can use our app to authenticate those images. And here's a slide of showing just that, where a user would take a picture of the packaging of the pill. It goes up to our cloud database and searches for that image. We do a match, and then we bring down that image back down to the cell phone, show it to the user, and also announce to the user what that pill is, where it was made, other information about that tablet. And this would help people that are illiterate or have low vision or even blind to be able to identify medications. So we think this is going to be a very powerful application for disabled people. Also, the application can announce the drug information in 52 languages, and so we're continuing to expand the capabilities of the audio software. And not only can we identify opioids, but we can also identify the medications that treat opioids. So here's a case where we're looking at buprenorphine, where it can identify the pill, and the patient would scan their pill on a daily basis, and that information of when and where the pill was scanned would be sent to our database and would have access by clinicians to see that a patient where that pill was registered to was actually taking their pills. So this allows us to have instant access to compliance information for that patient. So this keeps people on track. Here's again is a computer vision look of what that pill looks like up close. And on the right-hand side, you can see that the computer is able to automatically number each of the little granules in the pills. And so that becomes a very unique thumbprint signature for that pill. And this can also be done with other medications to help treat other types of alcohol abuse. So here we have one. And this is a final slide here where we have, it shows that the application called Deep Pill does machine recognition of the pills and allow us to track, trace, and authenticate pharmaceuticals post-market, as well as would help people keep compliance on their drug regimes. So we think it has broad applications for tracking medications. We also will publish this as a service in our website that would allow other applications to use our functionality within their applications. We realize that there are hundreds of healthcare applications out there, and that we would just become a feature of their applications to identify the pill. And then we expect applications to help people with behavior modification and helping people change their behavior in stopping those urges for addiction treatment. So we think that's a very powerful method that people are going to continue to evolve at in the future. So I think that's the end of my presentation. Can I take some questions?
Wonderful. We are now open for question, discussion, and answer. Also note that the webinar presentation is linked in one of the pods below the presentation. Feel free to submit your questions to Dr. Warren and Mr. Procop, and we will be fielding questions currently from registration. So the first question, what technologies have been found to be efficacious for increasing compliance and prolonged abstinence of opioid use?
I can take a crack at that one.
Absolutely.
There was a list produced by the Substance Abuse and Mental Health Services Administration that provides a document for e-therapy. And in that document, it has a listing of all the studies that e-therapy was able to help populations and how it was used. So I would encourage people to take a look at that document and see how it fits their particular situation.
I guess.
Our next question, how can, I'm sorry, please, Dr. Wren, go ahead.
It was an interesting question asking about technology to address opiate use disorder, and I just couldn't help myself but say that the biggest barrier to treatment there is access to medically assisted treatment and Suboxone, buprenorphine. So I don't think that it's a lack of technology per se, rather a lack of access to medications that have been found to be effective in helping people to recover and have improved functional outcomes.
Okay. Our next question comes from Keisha. Is the Deep Pill app currently available, and are there any plans to make it an iOS app?
We have applied for 2 grants, NIH grant and an FDA grant to work on this technology. We hope to have it launched next year, and it will be Android and iPhone.
Thank you, Dr. Wren. This next question is for you. How can rural health providers and health professionals get access to Psych Sit Rep?
As I mentioned, we are still in the early development phase of this product. So at this point, it's based off of the projects that I'm leading that we have going on. But I'm based in Georgia, and I have been in conversations with potential partners who are in rural areas, because I do think that in combination with telemental health services, this type of technology tool can really help to address some of the access gaps that rural communities face. If it's someone specifically interested that wants to reach out to me or to stay informed on our progress, be happy to get an email from them and put them on our listserv.
Thank you. Our next question. How can clinicians and health professionals leverage technology to mitigate the stigma around opioid use and to promote help-seeking behavior?
I can take a shot at that. There's a lot of applications right now on the Android platform. I haven't looked at the iPhone, but if they are able to do a search on Google Play, for instance, and bring up applications, there's quite a few applications that are put up by insurance companies. Aetna has got a couple of wellness and well-being apps. There's some drug addiction applications out there that help with behavior modification. There's quite a few free apps out there that try and help people modify their behavior, try and reduce the urge. There's some quit smoking apps, for instance, that are out there to help people stop the urge from smoking. And some of the research suggests with smoking that if they're able to just prevent the urge for the next 5 minutes, that urge will slowly go away and they won't have the cigarette. So I know that doesn't work with opioids, but these kind of behavior modification applications are available out there.
Another thing, I'm guessing that most people are thinking about, in clinical practice. So the most proximal awareness you may have is someone that has chronic pain that is taking more opiates, and in that case, I would also recommend that there are several apps about self-management for pain and also mindfulness building apps that can be very helpful. There's the unpredictability of pain, which I think causes a lot of distress for people, and they may also lack self-regulation and emotional regulation to deal with those acute pain episodes. And that's really one of the main reasons why those meditation apps and building mindfulness can be helpful for those patients.
I do think also that several of these applications have 24-hour hotline numbers that I think should be included in all those applications to give people sort of a safety net when they, are 2 o'clock in the morning and they're feeling kind of down and they need someone to talk to, that they can pick up their phone and they can call one of these hotlines and have someone walk them through it. So I think those support mechanisms have to be available, and they have to be more widespread through technology.
There's Crisis Text Line, which is a really great 24/7 app that provides live support really for people in crisis, but text messaging is, they found that that's a really effective way of engaging people, and it's more anonymous even than a phone conversation, so that might be a nice alternative to when you're telling people to call 911 or the crisis hotline. That crisis text line is a good resource for people.
Excellent.
Wonderful. We have a very poignant question from Amber. She acknowledges that we are currently discussing opioids and there is an opioid epidemic in the U.S. However, she also acknowledges that crack has been pervasive in many inner city communities and many suburbs. So are there any technologies that have specifically addressed the crack cocaine epidemic, and what can be done in marginalized or urban communities in the space of technology, or what applications can be utilized?
I'm not aware of any applications that specifically address crack cocaine use, and unfortunately there's not pharmacological treatment that has been helpful in either managing withdrawal from that substance or addiction. Oftentimes individuals that have substance use disorder involving crack cocaine have underlying mental health issues, be that formal diagnoses of depression. Again, using crack cocaine can cause depression, suicidality even, but addressing those issues as well as I think people often underestimate the role of emotion regulation. And, when people have difficulty regulating extreme emotions, that's when they usually will turn to a substance to try to numb out or avoid. The other really important thing is to think about the underlying traumatic exposures and untreated post-traumatic stress disorder that may also be fueling that crack cocaine habit and in those populations. And there are certainly many resources that are out there to help address trauma, to help to build resilience, some that are for emotion regulation. That's a tough question, though, because technology is an enabler, but it's an enabler for in this case, where you need a care continuum, and a technology solution alone is not going to be sufficient to address those challenges.
So how can health professionals and clinicians use technology to engage low-income patient populations who don't necessarily have access to technology?
Most low-income populations do have smartphones, in my experience, or some type of cell phone, and therefore they can benefit from these text-based applications. So that's one way. There's an example of, this is kind of from the OB space, but engaging people that have low English proficiency in kind of baby management through text messaging. So those are some kind of thoughts about how you might think about technology that would not require a high level of complexity to use. And depending on who's asking that question, I would encourage clinicians to think about developing technologies to solve some of these problems in collaboration with the end user as well, because a lot of times you develop a technology, you think it's really great, then you test it out, it's horrible. Well, you can involve people in the design process and see what are the real needs and how would you use the technology and what are some of the features that would be of interest to you. But all of that being said, a lot of my patients don't know about the things that are out there, the things that the VA has developed that are available to everyone, things for insomnia, and so I have a whole section of my phone which I keep these apps there, the ones that I can vouch for personally, and will use that as an opportunity to educate people and help them download it on their phone, especially for there's a nice CBT-I app for insomnia, and that's another one of those tricky conditions that you might think about turning to a medication for, but the medications may not be nearly as effective as really reinforcing those sleep hygiene recommendations that you give in 2 minutes the patient forgets when they leave.
I agree with that too. I found a $50 Android phone on Amazon, and it works beautifully for our applications with the latest and greatest operating system for $50, as well as most of the carriers, cell phone carriers, T-Mobile, Verizon, have low-income plans that in often most states they have actually a free plan available, and people just need to be aware of that. I'm sure they apply for it, and they can get free data plans to complement their phones.
Great. We have a question from Keisha. Keisha would like to know, does Psych Sit Rep software address patients who are bordering on developing an addiction?
Yes. So again, in the instruments that are used to assess that, the DAS-10 and the audit are the screeners for alcohol and drug abuse. So they're screeners, so they're not assessment tools. So if you have a patient that completes the whole screening complement, I would say, they may screen positive for some other mental health conditions, and you might see some of the items on the DAS and the audit show up as positive. And that would be an indication that you might want to ask more questions of that person in that visit, or if you had an integrated behavioral health consultant, you might bring that person in to try to do a more thorough assessment. But without the technology, you can also use these instruments yourself. You can do it the low-tech way. Again, use of these instruments are very underutilized in primary care settings. So you can even have the instruments out there for people to do on themselves and self-identify. I really am a fan of that because I think you want to engage people proactively in recovery. And what better way of doing that than from the starting point? Say, hey, do you really have a problem? Some people call them habits. It's like a minimized way that people talk about, addiction, and that self-assessment process also allows them in a kind of a comfortable environment to realize maybe this is a problem, and maybe, my loved one that keeps complaining about it has a point here.
Well, as we know, protecting patient information is vital. So can either of you speak to how your applications or your software reduces the risk liability to practitioners while simultaneously protecting the patient information?
Well, quickly I could just describe how we encrypt our information on the phone, and then while the data is sitting in our cloud database, the information is encrypted while at rest. So during transmission, it's also encrypted. So it can't be stolen, and it's using the Microsoft Azure platform that has all the government credentials for privacy protection. So we're confident that we're fully covered in that with True Medicines and DeepHealth.
And I'm not the techno person of this team, but I do know conceptually anytime data is being transferred, that's the point in time where it's most at risk, and those are when you want to make sure that there are appropriate encryption processes in place anytime the data is being transferred from one place to the next, and then obviously where it's stored.
Wonderful. Our next question, what role can data analytics play in helping to resolve the opioid crisis?
I'll take a first stab at that. Obviously with the right technology, there's a lot of ways that advanced machine learning and predictive analytics can be used to try to identify risk. So that's on the preventive side. And there are some that have developed technologies on inpatient using questions that they ask and try to predict, who may be at risk after discharge. Those are some ways that technology can be used to identify risk on the one hand, which is, I think helpful because then you can intervene on a high-risk group to either assess or refer for treatment or identify who might be your priority population. At the same time, it's important to make sure that you don't homogenize the group and, say, oh, this is generally a high-risk group, so we're going to target our resources here. So you need to think about any type of use of big data is only as good as the inputs that are put into it. And I think there are a lot of efforts, like for IBM Watson is working on some things, which again, you need quite a bit of data in order to have the most accurate predictive analytic algorithms.
With True Medicines, we have a sort of a low-tech approach. Every time a pill is scanned, we identify the GPS location of that pill where it was scanned. And using all this aggregated information, we can create a heat map of where the pills are being scanned in a city. And we can see, for instance, if we were looking at Tamiflu, for instance, we would see that a particular area of the city was hardest hit with the flu virus, and then that would allow public health people to concentrate on that area to do a little bit more public health service announcements or target that area for trying to reduce before it became an epidemic. So we think that just getting not big data, but just getting the location of where it's been scanned, we can leverage that tremendously in getting real-time data in where people are taking the medications and where they need help.
Oh, I'm so sorry, I was muted. Our next question comes from Sam. Do you believe that the use of technology will make it more challenging for rural providers to practice?
I would think, if anything, well, there's some caveats, right? So in some rural areas, internet connectivity can be an issue. So that we found in some of our assertive community treatment projects in Georgia where, you know, the environment of Wi-Fi was an issue. So that infrastructure issue aside, the actual technologies themselves theoretically should increase access because it doesn't rely on that spatial closeness to whatever the resource is, so giving information where it needs to go, being able to use technology to answer questions with, you know, without having expertise right there. So I would say for the most part, it should improve rural areas and close that disparity between rural and urban, but with the caveat of the infrastructure needs.
There's a law in place that allows telemedicine. If there's a video link, say it's FaceTime with a doctor on your phone, that application that has the FaceTime real-time audio link and video link with a doctor or health care provider, that type of application is covered under Medicare Part B. So I think a lot of technologists don't know that, and I think they should start building that technology into it so it will be covered and allow rural practitioners to, you know, have a phone call, a video phone call with their patients, as opposed to having the patients come in to the site.
So wonderful. So we have a question from Massachusetts. This is the first time we include community health workers into the care team to reach out and to work with opioid users. How should we use the community health worker role, and what tasks should they engage in when working with opioid users in the intervention process?
I mean, it depends on what interventions the community health worker is tasked to do primarily, and, you know, community health workers are used in very different ways. Some of them are provided by insurance companies for very specific disease-specific roles. Others are hired by the practice to do range of care coordination. I am a fan of using community health workers as cultural brokers between the clinic and the community, as well as making sure that they're properly trained to identify and recognize other needs. So I believe that you said that questioner was from New York. I don't know if it was New York City, but there's a big initiative in New York City to train in mental health first aid, which is helps people to identify mental health issues, teaches them a little bit about diagnostic categories and how do you get a person into care. The other thought is to think about peer specialists, certified peer specialists. So these are kind of, community health worker comes out of primary care, but there's peer specialists that have been in behavioral health land. If you find someone that has both of those characteristics, they may be a person of lived experience or a substance abuse counselor in long-term recovery that you can train as a community health worker, that person's going to have a lot more knowledge and skills and ability to help your patients, especially with some of their social determinant needs, which I think is where the healthcare system tends to know the least about where to go for what as it relates to their social needs. And that's how that member of the care team can be very helpful in that regard.
I believe there's a program in Boston called Anchor that uses ex-addicts to help outreach programs for Anchor, and they've had a pretty high success rate because people who are ex-addicts obviously know the problem, and they're very adept at getting some of these people into treatment programs. So I think that particular model is quite a good one, and I think that should be encouraged.
Thank you both. Next question. How can we leverage the use of telemedicine to manage the opioid crisis? Or opioid disorders?
I think David already mentioned one, which is using telemedicine for behavioral health. We wrote a paper in Psych Services about the underutilization of telebehavioral health across Medicaid population. But the other way that telemedicine can be used is, I was thinking mostly about that, using telebehavioral health. But in the VA, they have telebehavioral pain. So it's a group out, I think, in Yale that has expertise in pain management using behavioral therapies, and it's a specialized skill set. So one other way, say across the state, if you have an expert, they're usually concentrated in cities, you could provide teleservices. You'd have to figure out the priority population that would be at the highest priority of getting that expertise. But that's one way the VA expanded access to telebehavioral health for pain management, which was part of their effort to decrease opiates and decrease use of opiates along with other addictive sleep medications.
What is the impact of mobile health interventions on physician prescribing behavior?
I think it would depend on what the mobile health application is. If you have a mHealth application that helps you implement measurement-based care, then they help you to use medications in a more informed way because you know the symptom severity of the patient when they came in. If you use something like David's technology that helps the provider know that the patient isn't taking the medication as you would have hoped, which is probably true, then you can use that information to try to engage in motivational interviewing to help engage the patient and understand why are they having a hard time taking the medications as prescribed. So again, I think the overall concept is technology is not going to do the thing for you, but it can be used as an enabling tool to help give you the right information at the right time that's actionable and hopefully give you more efficiency in your practice. And to me, it's about improving physician prescribing practices because you have the information that you need to make decisions about what you should do regarding medication.
I also think a clinician could split their patients into high-risk and low-risk populations. The high-risk people, you would want to closely monitor their compliance with your program. The low-risk, you could give them the software application and monitor them maybe less frequently and let them kind of go off and do the program on the electronic phone, for instance. And I think this would allow the doctors to kind of concentrate their time on the high-risk patients. So I do think we'll help them with their time management.
Okay, thank you. Next question. Can you suggest any tools that are free to download and which are currently available while someone is a vendor at a conference?
For Psych applications, there is a website, which I can't think of the name, but I could find it and send it out, that helps to kind of compare different psychiatric health applications. There are conferences specifically regarding health technology, the HIMSS conference, which if you're like super interested, I guess you could go there and see what's on the front lines of technology innovation.
The website by Sam Hasser, the Substance Abuse and Mental Health Services have been, they have every year they do a challenge for applications for MAT applications, so medical assisted treatment programs, and so they have a whole gang of applications up there that vie for the award. I believe it's $20,000, and maybe next year might be $50,000 award. So there's quite a few applications up there on that website. So that's something to check out.
Okay, wonderful. We're down to our final two questions. The first question is from Yanette. Do you need to take HIPAA training to implement a mental health application?
I'm going to try to answer this question. So if the application was developed to be HIPAA compliant, then you wouldn't need special HIPAA training to use it because it speaks to how the application works. If you're an individual user, you're using it for your own purposes, that's not relevant. If you're a healthcare system that's implementing a technology, you probably already are required to do HIPAA training. I don't know how else to answer that.
I think you did a phenomenal job. So we will wrap with our final question, and this is for both Mr. Procop and Dr. Wren. What do you see, essentially, what do you forecast in the next 10 years for technology, mobile health interventions in the space of addiction treatment or pain management?
I'll give a quick answer. I see software getting smarter and more personal with the user, and I think we're really going to have personal assistants that can help you manage your medications, manage your appointments, help you in your day-to-day life, like your own personal secretary or assistant that helps you just manage your life. And I think it'll help you manage your medications as well as other issues with daily life. And I think applications are going to get smarter and smarter to be able to know the person that owns them and allow them to help them in ways that are needed. So I think the future is very bright for smart technology.
Yeah, I would agree with that, and I think it's important for those of us that are concerned about health equity that we make sure that the most disadvantaged populations can benefit from those technology interventions, that we're not the last to receive them, and that they're not used to further expand health disparities by targeting certain groups of populations.
Thank you. Thank you both, Mr. Procop and Dr. Wren, for an extremely engaging and informative presentation. And I thank you, participants, for battling through our tech issues at the beginning of our Technology to Solve Issues webinar. Additionally, we encourage you to complete the full opioid use management series. Part 4 is scheduled for November 15th, and Part 5 is scheduled for December 13th. As I stated at the beginning of the webinar, the presentation is available for download now, and you will receive an email with directions on how to access CME credits. On behalf of the National Center for Primary Care, we thank you for your attendance at today's webinar, and have a wonderful evening.